It is my great pleasure to introduce our first speaker, Dr. Kevin Tucker.
Good morning. Can you hear me? So it is my pleasure to be here with you today. It's a little daunting to be the first speaker of the day, and this is my first in-person talk since the pandemic began. So I'm a little out of practice in providing education in person. So if I stumble, please bear with me. So it's great to be with you to talk about what's new and innovative in chronic kidney disease, and specifically to talk about pharmacology. I was telling Mona earlier that 10 years ago, this would have been a very difficult talk to give because not much had been happening new pharmacologically. We really hadn't had any new innovations in chronic kidney disease since the advent of ACE inhibitors and ARBs. But as you'll see, I'm going to focus a lot on diabetes management in chronic kidney disease because that's where we have had an explosion of new therapies and new knowledge and understanding. That's really what I want to impart today. And we're also going to focus on a little bit of the controversies around racial disparities and measuring glomerular filtration rate because that's been in the news a lot over the last 2 years as well. So you heard my bio. I'm from Alabama. Anybody here from Alabama? A few people. Anybody here from Massachusetts? That's where I reside now. So not many people from New England. So hopefully everyone will get something out of today's presentation. Feel free to stop me as we go. I like to take questions. We're going to do this in a case-based format. So after each case, we'll stop and pause for a few questions, and then there'll be time for questions at the end. I have no disclosures. So the learning objectives for today are for us to articulate strategies for retarding progression of chronic kidney disease and treating complications of chronic kidney disease. Secondly, we want to describe the role of newer agents in retarding progression of diabetic and non-diabetic kidney disease. And thirdly, we want to develop conservative management plans for patients with advanced kidney disease. So we'll start with a case. So this is a case of a 53-year-old woman with diabetes and hypertension who presents for follow-up. She feels well, has no complaints. Her blood pressure is consistently greater than 145 over 90 millimeters of mercury. She has no edema. Her past history is notable for diabetes, hypertension, hypothyroidism, and being overweight. Her medications include a calcium channel blocker, amlodipine. She's on thyroid replacement, and she's on metformin. And her labs are notable for a potassium of 4.7, serum bicarbonate of 26 millimoles per liter, creatinine of 1.01, a hemoglobin A1C of 8%, and a urine albumin to creatinine ratio of 389 milligrams per gram. So the first question, which I'm going to ask people to raise their hands for, we're going to do it old school. What additional medication may be beneficial in retarding the progression of her chronic kidney disease? So the options are acarbose, saxagliptin, losartan, or insulin. So first, who votes for acarbose? How about saxagliptin? Okay. A couple votes for saxagliptin. How about losartan? Okay. And finally, how about insulin? Okay, great. So the correct answer is C, losartan. So all of the other medications may be helpful in achieving better glycemic control. However, none of these has been proven beneficial in retarding progression of chronic kidney disease. So of those choices, the only one for which we have clear data that the addition of that medication may retard progression in diabetic kidney disease is losartan. So first, let's start with the importance of blood pressure control. Why do we worry about blood pressure control? Blood pressure control is important because it helps to retard progression of chronic kidney disease. But remember, in addition, what do our patients with chronic kidney disease die from? They don't really die from their kidney disease. What they die from is cardiovascular disease. So the importance of blood pressure control is not only that it retards the progression of kidney disease, but it also lowers cardiovascular risk. And our KDIGO guidelines, that's the Global Kidney Disease Outcomes Guidelines, suggest that we target a systolic blood pressure of less than 120 millimeters of mercury. Now, 10 years ago, I would have been focusing just on blockade of the renin-angiotensin system because that was all that we really had. Why is blockade of the renin-angiotensin system important? It's important because it retards the progression of proteinuric renal diseases, for example, diabetic nephropathy. It reduces proteinuria in many forms of kidney disease. It retards the progression in hypertensive nephrosclerosis, that is, patients who have non-proteinuric kidney disease that's attributed to hypertension, and it lowers the blood pressure. So I want you to pay attention to this heat map for a minute. And what this heat map shows you is that the prognosis of chronic kidney disease is not only tied to the glomerular filtration rate, but it's also tied to the amount of albuminuria. And if you don't take anything else away from today's talk, I hope that you'll take this away, that it's not just the glomerular filtration rate that's important, it's also the presence of albuminuria and the amount of albuminuria. So if you look at the bottom right-hand corner, you can see that those who have both the highest degrees of albuminuria and the lowest GFR are those who are at the greatest risk of progression. So when you're thinking about managing chronic kidney disease in your patient population, assessment of albuminuria is equally as important as assessment of the GFR. And what we see time and time again is that the creatinine is measured for GFR, but there's no measurement of the urine albumin excretion. So take that message home, if you don't take anything else home, is that we gotta look at both, because we gotta target albuminuria as a risk factor for progression of chronic kidney disease, and equally importantly, this same heat map ties to cardiovascular risk. So those who have the greatest degrees of albuminuria and the lowest GFR are also at great risk of cardiovascular events. And those are the things that we want to target. So remember this heat map. The more albuminuria combined with a low GFR, the greater the risk of progression of chronic kidney disease and the greater the cardiovascular risk. So what are the indications for RAS blockade, or ACE inhibitors and ARBs? So diabetic kidney disease, both in type 1 diabetes and type 2 diabetes. We have the greatest amount of evidence with ARBs for type 2 diabetes, and we have greater evidence with ACE inhibitors for type 1 diabetes. But we think that the two are probably interchangeable in both type 1 and type 2 diabetes. Any form of proteinuric kidney disease deserves RAS inhibition. Hypertensive nephrosclerosis, that is, patients who have kidney disease that's thought to be due to hypertension and low-grade proteinuria. And finally, any patient who has even low-grade albuminuria should be on RAS blockade. So let's talk a little bit about the evidence for angiotensin receptor blockers in type 2 diabetic kidney disease. So what's the evidence? Well, the primary evidence comes from the RENAL study, which was published some time back now in the early 2000s in the New England Journal of Medicine. And it took about 1,500 patients and enrolled them in a double-blind placebo-controlled trial in which losartan versus placebo was added to usual care. And the outcomes were pretty striking. There was a 16% reduction in the primary outcome, a 25% reduction in the doubling of serum creatinine, a 28% risk reduction in end-stage renal disease, and a 35% reduction in the level of proteinuria, that is the albumin to creatinine ratio. Fortunately, it didn't have a mortality benefit. There was no effect on the death rate. But in terms of these other outcomes, there was clear evidence of a diminution of those who are reaching dialysis, and that's really what we want to stop. So, pay attention to these numbers, because when we look at some of the data from some of the newer agents, like the SGLT2 inhibitors, you're going to see even greater risk reductions, and this was considered pretty good. This was considered very good risk reduction, but we're going to show you some even more striking risk reduction with some of the newer therapies that have come online since then. What about ACE inhibitors in hypertensive nephrosclerosis? So we're going to talk about the ASK study, and let me just take a step back and tell you why the ASK study was important. So I went to medical school. I'm going to give you my age here. I started medical school in 1986. And at that time, I remember being taught ACE inhibitors are good, but they don't work very well in black patients. And so ACE inhibitors were underutilized in patients of African descent for many years because we had been taught they don't work so well in people of color. Well, there came more and more evidence that ACE inhibitors did more than lower the blood pressure. Maybe they had an effect on the kidneys independent of the blood pressure lowering effect. So the NIH said, let's do a study, and let's do a study specifically in African American patients who have kidney disease that's due to hypertension. And we're going to ask this question: how do ACE inhibitors perform compared to other drug classes that may actually be better in lowering the blood pressure? So they looked for African American patients who had kidney disease and hypertension. They excluded patients with other causes of kidney disease, like diabetes or lupus or hepatitis. And they randomized them to amlodipine, 5 to 10 milligrams per day, versus ramipril, 2.5 to 10 milligrams per day. You could add other agents as needed to achieve the blood pressure targets, and they used mean arterial pressures, and these were fairly generous blood pressures. In other words, wasn't aiming to lower the blood pressure really low. So they target MAPs of 102 to 107, or MAPs less than or equal to 92. And what they found in the ASK study was that those who were randomized to ramipril, the ACE inhibitor, had a 38% risk reduction for the outcome of GFR event, end-stage renal disease, or death compared to amlodipine, and a 41% risk reduction for the outcome of ESRD or death with ramipril compared to amlodipine. So even though the calcium channel blocker may have been better in lowering the blood pressure, here we had evidence clearly showing that ACE inhibitors perform better than the calcium channel blockers in reducing the progression of kidney disease. So this was really a game changer because it undid everything that I had been taught and many others of my generation had been taught about whether or not we should be prescribing ACE inhibitors to our patients of African descent who had hypertension and kidney disease. So a really important study. Now, the question always comes up, though. ACE inhibitors are great, but in our patients with chronic kidney disease, we're worried about the potassium. Or is it too late? Is it too late because it may actually push them towards dialysis? So that question I would get many times at teaching conferences like this, and I would give my best guess, but really didn't have a good evidence base for it until this paper was published that I'm going to show you. So this paper was published in the New England Journal in 2006. And what they did in this study from China was they looked at individuals with chronic kidney disease, and they said, okay, we know that for people with less advanced chronic kidney disease who have proteinuria that they should be on an ACE inhibitor. But what we don't know is people with more advanced kidney disease, does it still help? And so they used a creatinine cutoff. They didn't use a GFR cutoff, and I think the creatinine cutoff was around 3. So all the patients in group 1 had creatinines less than 3 or so, and the patients in group 2 had creatinines of 3 or greater. And for the patients with the higher creatinines, they randomized them to benazepril or placebo. And what you can see is that those who were treated with benazepril, whether they had a relatively preserved GFR, creatinine less than 3, or more advanced chronic kidney disease, did better compared to those who were on placebo. So even in our patients who have more advanced kidney disease, ACE inhibitors retard progression. So now, my answer to the question is, when do we stop? Is I say don't stop. Don't stop unless we have to because of hyperkalemia, because even in patients with stage 4 chronic kidney disease, we may be able to stave off the need for dialysis by keeping the patient on an ACE inhibitor. Now, obviously there's greater risk of hyperkalemia the greater the creatinine or the lower the GFR. But we're going to talk in a later case about strategies to help reduce the risk of hyperkalemia in patients who have advanced chronic kidney disease. Okay, so I want to stop there, pause for a minute, and see if there are any questions about any of the concepts that we've covered. Yes, ma'am. So I'll repeat the question. The question was, do we know whether or not the benefit occurs in people of color of many different races and ethnicities? And the answer is probably so. The ASK study recruited specifically patients who were African American, and so typically people who came to who were descended from the African diaspora, descended from slaves in the United States. I think that, however, that the benefit probably occurs across races and ethnicities. The reason that African Americans were studied specifically was because African Americans were thought to respond less well in terms of blood pressure. But I think the kidney benefits, I think, are probably spread across many different races and ethnicities. But the reason that that population was studied was because of what had been learned early on about the pharmacology of the blood pressure response. Yes, sir. The ASK study was published in the early 2000s. The study itself was done, I remember it because it was occurring when I was a fellow, so that was in the late 1990s and was published in the early 2000s. Yes, ma'am, and then we'll come back to you. Question, which is better, ACE or ARB? I think the two are equivalent. I think that either one will provide the benefit in terms of retarding progression of chronic kidney disease. Remember that we probably have more patients who have intolerances because of angioedema or cough to ACE inhibitors, so sometimes we'll end up switching from ACE to an ARB. Sometimes it may have to do with insurance coverage. So interesting, I'll just tell you my own personal anecdote. My mother had a cough to an ACE inhibitor. When I got started on an ACE inhibitor, I had the same cough. So now I take losartan. But I think that the benefits are probably equivalent from an ACE to an ARB. Yes, sir. So the comment was that there are still clinicians who will not order an ACE or an ARB for African American patients, and I think that's why we're here, educate to get away from some of the mythology, because I think that mythology persisted for many years, and that was really why the ASK study was done, to try to see even if it was true that there was no benefit in terms of blood pressure, or less benefit in terms of blood pressure control, even if you accept that, then we have data that the progression of chronic kidney disease is a separate question. Okay, so second case. 67-year-old man with diabetes mellitus type 2, chronic kidney disease, developmental delay, is referred to the hospital with asymptomatic hyperkalemia. This is a true case. This is one of my patients whom I followed for a number of years. His medical history is fairly complex: type 2 diabetes, hypertension, CKD, and anemia of CKD. He had trisomy 21, congestive heart failure, and atrial fibrillation. He was on the usual medicines in addition to insulin, lisinopril, amlodipine, diltiazem, metoprolol, loop diuretic, and aspirin. These were his labs on presentation to the hospital. His creatinine was 4.7. His potassium was 6.3. His bicarbonate was 16. And his hemoglobin was 9.9. So, question for you is, should he have an AV fistula created for dialysis? How many of you would vote yes? Let's create a fistula in this patient. I see one hand raised over here. And how many of you say no? Great. So there's no right answer here, but I want to walk you through sort of the thinking that I think has to go through in a consideration of a case such as this one. So we all learned these indications for dialysis: acid-base disturbances, electrolyte abnormalities, and usually the one that drives us to initiate dialysis is hyperkalemia. Ingestions, this is typically in the hospital setting where we have someone who comes in with an acute poisoning like ethylene glycol or methanol. Fluid overload, that's often one of the reasons that we end up starting a patient on dialysis. Patient no longer responds to diuretics and is drowning in fluid. Uremia, which is a clinical syndrome, and it's hard to define. And I like to say that I follow the Justice Potter Stewart rule in defining uremia. So for those of you who are history buffs, Justice Potter Stewart was a Supreme Court justice who ruled in a famous case involving pornography. And he said, "I don't know how to define it, but I know it when I see it." And that's what I think nephrologists think about uremia. It's hard for us to define, but we see enough patients, we think we know uremia when we see it. But it's a complex set of signs and symptoms. It may be nausea and vomiting. It may be anorexia, maybe dysgeusia, loss of taste perception. Pruritus can be a late complication, itching, severe itching, and then pericarditis. We rarely see anymore because it really takes prolonged uremic state for someone to develop uremic pericarditis. But when you are confronted with a patient like the patient that I presented in this case, I really think you have to go down the renal replacement decision tree. And this decision tree is fairly complex. You have to decide first, should this patient be placed on renal replacement therapy? If the patient should be placed on renal replacement, then the best first option is a kidney transplant. But most of our patients aren't able to get a preemptive transplant. So most patients end up going on dialysis first. If the patient is going on dialysis, then the question is home or in-center. Now, we think of the default in the United States as being in-center dialysis. Only about 8% or so of our patients in the United States do home dialysis therapies. Compared to many parts of the world, we are far behind in terms of utilizing home therapies. One of the ways in which I have now begun to sell my patients on home therapies is that I talk to them about the COVID-19 experience. In March of 2020, when dialysis patients, in-center hemodialysis patients, were dying of COVID-19, none of my home patients got COVID because they were dialyzing at home. They didn't have to get into public transportation or get into a chair car to get to a dialysis center. And when they got to the dialysis center, they weren't exposed to other patients. So I used that. It was really a game changer in terms of safety for our patients who were on home therapies. If the patient chooses home therapies, then you still have another choice: home peritoneal dialysis or home hemodialysis. Now, I said only about 8% of patients in the United States do home therapy. And of that 8%, the overwhelming majority do peritoneal dialysis. Home hemodialysis is an option, but it's a little bit more complex to learn. The training takes longer, it's a little bit more complex, and you need a partner for the most part. Whereas home peritoneal dialysis, even patients who live completely by themselves can do it. I think home hemo will grow with some of the initiatives that are coming out of Health and Human Services, but I think peritoneal dialysis is still going to be the more widely utilized therapy. Now, conservative or non-dialytic therapy may be appropriate in some patients. There's no increase in survival and no improvement in quality of life in the frail elderly who are started on dialysis. So this is the second big take-home point that I want you to leave here with, is that many times we think of dialysis as being, the next step for all of our patients who have chronic kidney disease. But the data really suggests that if you're elderly and frail, your survival within 1 year is less than 50%. And so I think we have to start having more honest and difficult conversations. And that's where the primary care physician, the nurse practitioner, the PA, or whoever is seeing the patient in the office really has an important role, because they are often the ones who are having the first conversation. And I think understanding what's important to the patient really helps us as nephrologists to understand where we should go with respect to conservative therapy versus dialytic therapy. If the patient decides on dialytic therapy, then we need to make sure that we create a vascular access if the patient's going to do hemodialysis or place a peritoneal dialysis catheter. And at the same time, we need to manage the nutritional complications like hyperkalemia and malnutrition. And we need to manage the other complications like anemia. So, let's talk a little bit about the survival of our elderly patients on dialysis versus with conservative therapy. And you can see that for those who have low comorbidities, being placed on renal replacement therapy does confer some survival benefit. But for those who have high comorbidities, the curves really kind of overlap. So are we doing our patients a favor when they're in the nursing home, they're frail, they're cachectic, and we know that we aren't going to enhance their quality of life nor prolong their life with dialytic therapy? So I want to ask another question about the same patient, because remember, he had a potassium that was in the 6s. So which of the following strategies may be helpful in controlling this patient's serum potassium? And the choices are dietary potassium restriction, treatment of metabolic acidosis, a loop diuretic, adding sodium zirconium cyclosilicate, or all of the above. So who votes for dietary potassium restriction? Okay, a few votes for that. Who votes for treating the metabolic acidosis? Okay, a couple votes for that. What about a loop diuretic? I'm a big proponent of loop diuretics in treating hyperkalemia. What about sodium zirconium cyclosilicate? First of all, everybody know what sodium zirconium cyclosilicate is? Okay. The brand name is Lokelma, and we'll talk a little bit about that in the upcoming case. What about all of the above? Okay, great. So all of these strategies may be helpful in treating this patient's hyperkalemia. So let's talk a little bit about hyperkalemia specifically. So this is what I call the hyperkalemia perfect storm. Any patient who has pre-existing CKD is at risk. But add a few things to it. Add volume depletion and ACE inhibitor. So when your patients get sick, they have nausea, vomiting, and diarrhea, and they're on an ACE inhibitor, that's a recipe for hyperkalemia. Add into the mix some non-steroidal anti-inflammatories that only heightens the risk. And then Bactrim, trimethoprim sulfamethoxazole. So in case you're not familiar with how Bactrim causes hyperkalemia, it's not that it causes acute renal failure, but what it does is the trimethoprim component acts as a potassium-sparing diuretic. So it blocks the epithelial sodium channel, just like drugs like amiloride do. So always remember that even without acute kidney injury, adding trimethoprim sulfa in someone with pre-existing chronic kidney disease can cause hyperkalemia. So there are also risk factors for hyperkalemia with the use of drugs that interfere with the renin-angiotensin-aldosterone system. So we talked in case 1 about the importance of ACE inhibitors and ARBs, but you have to know what are the other risk factors that make those patients at higher risk for developing hyperkalemia. So chronic kidney disease, diabetes, decompensated congestive heart failure, volume depletion, older age, non-steroidal anti-inflammatory drugs, beta blockers, heparin. Heparin blocks the release of aldosterone, so acts as a potential risk factor for hyperkalemia. Spironolactone and other potassium-sparing diuretics, and, as I just mentioned, trimethoprim. So, what is my approach to patients at risk for hyperkalemia caused by RAS inhibitors? 1, know what the GFR is. The lower the GFR, the greater the risk, and the more vigilant you have to be. Discontinue other drugs that may cause hyperkalemia. So if you know your patient's taking, say, non-steroidals periodically for joint pains, warn them about the potentiation of the risk of hyperkalemia with non-steroidals and try to get them to switch to some other analgesic. Prescribe a low potassium diet. Prescribe a thiazide or a loop diuretic. Prescribe sodium bicarbonate to correct the metabolic acidosis. Start with a low dose. And when you start with a low dose, if you want to escalate, recheck within a week of initiation or of a dose escalation. So these are the strategies that I use so that I can try to get ACE inhibitors on board, even in patients that I know are at higher risk of hyperkalemia. And then how do we treat hyperkalemia chronically? Well, dietary potassium restriction. And I'll come back to this first bullet point because my thoughts about this have evolved over the last few years. Treat the metabolic acidosis associated with a type 4 RTA, hence the sodium bicarbonate. And let me just take a sip of my coffee. Use loop or thiazide diuretics. They help to augment the urinary excretion of potassium. And then we have drugs that help us to get rid of potassium through the GI tract. So everyone is familiar with sodium polystyrene sulfonate, Kexalate. Kexalate has fallen out of favor, at least at my institution, because of the risk of intestinal necrosis. Though rare, it is reported. And so we have started to use these 2 newer agents much more commonly, patirimer and sodium zirconium cyclosilicate. So I call them new-ish agents to treat hyperkalemia because the New England Journal paper was published now 7 years ago. And the first one is patiromer. It's a non-absorbed polymer that binds potassium in exchange for calcium. And the second is sodium zirconium cyclosilicate. It's kind of a mouthful. It's a highly selective cation exchanger that traps potassium in the intestinal tract in exchange for sodium and hydrogen. So we use these agents fairly liberally in our practices, even in patients with advanced CKD, in order to be able to keep them on ACE inhibitors and ARBs. Now, I said my first bullet point was dietary potassium restriction. And I have sort of evolved my thinking about this over the last few years, especially as I've used more patiromer and sodium zirconium cyclosilicate, because we are depriving our CKD patients of some of the most nutritious foods that may actually have other benefits. And so I now am trying, if I can, to don't say completely avoid some of the fruits and vegetables that we know provide other benefits. And so if a patient tends towards hyperkalemia and if the insurance will cover it, I may use an agent like sodium zirconium cyclosilicate. Example, I grew up in the South. I have a garden now. We grow tomatoes. Tomatoes are very nutritious. And, if you routinely tell your patients, avoid all high potassium containing foods, there's a whole class of nutritious fruits and vegetables that they're not going to be able to enjoy. And I wonder if we're not potentiating some harm by depriving our patients of some of these really nutritious foods. So I've begun to rethink what I'm telling my patients and am using some of these other agents to try to allow them to have more dietary flexibility and keep them on drugs like ACE inhibitors and ARBs. So why new agents to treat chronic hyperkalemia? The safety profile. There's less intestinal necrosis compared to sodium polystyrene sulfonate. And I think there's greater patient acceptance. So caxylate is not such a pleasant drug to take. And I think there's better patient acceptance with newer agents like patiromer and sodium zirconium cyclosilicate. And it allows us the ability to continue RAS inhibitors. So let's go back to the patient. So this patient was in the hospital, and I'd had many conversations with him and his sister, who was his healthcare proxy and his primary caregiver. And she thought that, first of all, the ability to explain to him and have him cooperate with sitting in a chair 3 times a week for chronic hemodialysis was going to be exceedingly difficult. And so we opted in a patient-centered approach with his healthcare proxy to opt for no dialysis and to try to treat him conservatively. So we did all these things to bring his potassium down. I stopped the ACE inhibitor. His potassium remained high even after stopping the ACE inhibitor. Started him on daily patiromer in order to keep his potassium under control. So this is one example of a patient in whom I have taken a conservative non-dialytic approach because I thought it was the right thing to do in this particular setting. But these are very difficult conversations, and they require an ongoing reevaluation of what's important to the patient in terms of quality of life versus quantity of life. So I'll stop there, and let's take some questions about the second case, because we covered a lot of territory. Yes, ma'am. So the question is, what are the side effects of the newer medications? So the newer medications are pretty well tolerated. They don't cause diarrhea, but the potassium goes out through the stool. But you don't get a lot of complaints about diarrhea. Now, some patients, have some GI upset with one versus the other, but for the most part, they're pretty well tolerated. They still have to be mixed. It's a slurry that comes in a powder. It has to be mixed, and so it's not like just taking a pill, but it does seem to be more palatable than sodium polystyrene sulfonate. Yes, ma'am. So the question is, do you use them daily or do you use them intermittently? They can be used in both settings. So in the hospital, so for example, say it's Sunday, and on the labs, patient has a potassium of 6, and there's no dialysis staff in-house, and I'm a little bit worried that maybe potassium at the end of the day on Sunday is going to be 7, and so I'll use it in that setting to bring it down acutely. So that's one example. But the point of these medications is for chronic use in order to be able to keep the patients who tend towards hyperkalemia on their ACE inhibitor or ARB. And that was really what the initial studies about these drugs showed, that for patients who are on chronic RAS inhibition, you can keep them on the ACE inhibitor ARB and keep the potassium under reasonable control. Yes, ma'am. What are the recommendations regarding pricing? So that's the elephant in the room. As with any new medication, these drugs are more expensive often than the older medications. And so it requires a lot of work with respect to prior authorizations, or sometimes there are patient benefit programs that may provide coverage for the medications. But it is a challenge in some cases, depending upon the patient's insurance. So in our own setting, we have tried to work with our insurers that our patients commonly have to make them see the potential benefit of these medications. The benefit being that we can keep patients on RAS inhibitors, which will retard progression of chronic kidney disease and ultimately save money by staving off the need for renal replacement therapy. And that approach, I think, has helped us in order to be able to improve the coverage, but I know the coverage is very spotty for these medications across the country. Yes, sir. So what was my recommendation for this patient? Yes. So my conversation with the patient, it was primarily with his healthcare proxy, because his comprehension was very limited, was that it was going to be very, very difficult for this patient to sit in a chair 3 times a week and tolerate hemodialysis, because you couldn't explain to him why he had to sit there. I mean, it was hard for him to sit through just a clinic visit. And so we made the decision based upon that finding alone that it was not in his benefit. Plus, we talked about the data. Patients with many comorbidities, the survival benefit is not that great. And so given that whole picture, we made the decision for conservative therapy. Yes, ma'am. How much longer did this patient live? I think this patient lived another 6 or 7 months. Yes, ma'am. What's the potency of trimethoprim sulfa as a potassium-sparing diuretic relative to spironolactone? No, I don't. I'm not sure what the relative potency is. What I can tell you with some degree of certainty is that clinically, we see a lot of trimethoprim-induced hyperkalemia. So my best guess is it's probably fairly potent with respect to spironolactone, just based upon my clinical experience. But I don't know the pharmacology of what the relative potency is relative to spironolactone. Yes, ma'am. Oh, the question is, what's the onset of action? So the onset of action for both of these medications is within hours. So usually about 4 hours, 4 to 6 hours, you'll get a lowering of the potassium. Yes, ma'am. What is my threshold for treating hyperkalemia? Very good question. So in a chronic dialysis patient, I typically won't treat it unless it's 6 or greater. And the reason is that I think that many of our patients develop a degree of tolerance to mild degrees of hyperkalemia. And we know this because our patients, when we get their routine labs, when they come in for dialysis on a Monday, if they're a Monday, Wednesday, Friday patient, they've missed dialysis for 2 days, and potassium will be in the 6s. And so I think that my threshold is probably around 6. What happens in the hospital, though, is that these patients are under the care of non-nephrologists as a primary team, and their thresholds are much lower, so they tend to get treated when the potassium is in the 5s, whereas, if I had seen it first, I probably would not have treated it, but I find a lot of these patients in the hospital setting, because naturally our hospitalist colleagues are less comfortable with that kind of potassium in any patient, so they tend to have a more conservative target than I do personally. Yes, sir. Okay. Complex question, thank you. My preferred agent for blood pressure is chlorthalidone. I use a lot of chlorthalidone because it is longer acting than hydrochlorothiazide. And most of the studies, hypertension studies that have used a thiazide diuretic have used chlorthalidone. So one of the classic studies that came out in the 1990s was the SHEP study, Systolic Hypertension in the Elderly Program, which looked at using a single thiazide diuretic and showed important stroke reduction, and that was chlorthalidone. Chlorthalidone still remains underutilized with respect to hydrochlorothiazide. We get comfortable with drugs that we know and we prescribe, and I think that for whatever reason, hydrochlorothiazide has been more commonly used, but I think in the nephrology community, a lot of us use a lot more chlorthalidone than is used in the primary care community. I like chlorthalidone because it's longer acting, and we have actually a fair amount of data from many, many clinical trials, including the SHEP study, amongst others. Yes, ma'am. Good point. Coverage and combination drugs. So many of the combination drugs are not combinations with chlorthalidone. They're combinations with ACTZ. Point well taken. Okay, let's move on to case 3. 53-year-old woman with chronic kidney disease due to diabetes presents for follow-up. She feels well, no complaints. Past medical history, diabetes, hypertension, hypothyroidism, and she's overweight. She has labs similar to the patient in the first case. Potassium 4.7, bicarb 26, creatinine 1.01, hemoglobin A1C 8, urine albumin to creatinine ratio 389 milligrams per gram. She's on a calcium channel blocker, ACE inhibitor, thyroid replacement, and insulin. What additional medication may be beneficial in retarding the progression of her chronic kidney disease? And the choices are carbose, saxagliptin, canagliflozin, spironolactone, or metformin. So, any votes for carbose? How about saxagliptin? One vote I saw for saxagliptin. Canagliflozin. Okay, a few votes for cana. Spironolactone. A couple of votes for spironolactone. And, and I put 2 D's down, sorry. And metformin. Okay, so this is take-home point number 3. Canagliflozin Remember the SGLT2 inhibitors for diabetic chronic kidney disease, because we have more and more data, which I'm going to roll out to you. So we talked about the importance of blood pressure control and blockade of the renin-angiotensin system, and 10 years ago, this was all I had to talk about. But now we know that the drug class matters with respect to how we treat the diabetes. Not all diabetes medications are created equal. Despite the widespread use of RAS inhibitors, diabetes remains the leading cause of end-stage renal disease in the US. Some glucose-lowering agents appear to have glucose-independent effects on diabetic nephropathy and its progression. And these are the GLP-1 analogs and the sodium glucose cotransporter inhibitors, SGLT2 inhibitors. So, importantly, even though these newer medications may not lower the hemoglobin A1C as much, their effects on diabetic kidney disease are much greater than many of the agents that lower the hemoglobin A1C more. So what are the GLP-1 agonists? Let's talk about those. These are peptides that have a number of effects. They have effects on the brain, so they act as appetite suppressants. They have effects in the heart in terms of cardioprotection. They decrease glucose production, and they increase insulin sensitivity. So let's talk about the GLP-1 analogs and one of the recent trials that's come out called Amplitude-O. So in a randomized control trial, an extendin-based GLP-1 agonist, and extendin-based simply means that it's one of the ones that's made from this reptile venom. Epiglenitide, and I have to pause because these medications are sometimes hard to pronounce. Epiglenitide or placebo was added to usual care in patients with type 2 diabetes and either a history of cardiovascular disease or chronic kidney disease, plus one other cardiovascular risk factor. And the subjects were stratified or not based upon whether they were receiving an SGLT2 inhibitor. So the renal outcomes in Amplitude-O were a 32% reduction in the composite renal outcome, a 21% reduction in the expanded major adverse cardiovascular event composite outcomes, a 27% reduction in MACE or death from non-vascular causes, cardiovascular causes, and a 27% reduction in incident MACE. So remember when we were talking about the benefit of ACE inhibitors, we were talking about benefits that were maybe in the low 20s, high 20s, and now we're talking about benefits in the 30s in terms of composite renal outcomes. So what about GLP-1 agonists and renal outcomes? Well, we're still awaiting trial data looking at GLP-1 agonists and other outcomes in a kidney-focused clinical trial. And by that, I mean we have lots of data that have come out from the cardiovascular trials in which they've looked at kidney outcomes as a secondary outcome. But there are some ongoing trials that are being designed specifically to look at the kidneys. And so these are the effect of glucagon-like peptide 1 receptor agonism on diabetic kidney disease, the effect of lixisenatide on the renal system, the Elixirs trial, and the FLOW study, the effect of semaglutide versus placebo on the progression of renal impairment in subjects with type 2 diabetes and chronic kidney disease. So stay tuned for more trial data, but suffice it to say that based upon what we know from the heart trials, that the kidney outcomes look pretty good. Now we have much more data, kidney-specific data for the SGLT2 inhibitors. So what are they? These are drugs that block the sodium and glucose transporters. They block the reabsorption of glucose at the proximal tubule. They're effective even in individuals with stage 2 or stage 3 chronic kidney disease. They lower the weight and the blood pressure probably through a diuretic effect, and they have a relatively low risk of hypoglycemia. This is a diagram that shows you where they work. So they work in the proximal tubule. So they put out glucose in the urine so that it's not reabsorbed here in the proximal tubule. So the Credence trial, I really consider a game changer. So this was a study that was published a few years ago now. Some 4,000 patients were randomized, and these patients all had albuminuria with urine albumin to creatinine ratios between 300 and 5,000. The GFRs were as low as 30. They were all importantly on prior RAS blockade. The primary outcomes were composite of end-stage renal disease and doubling of the serum creatinine or death from renal or cardiovascular causes. Okay, what were the outcomes? A 30% reduction in the composite renal outcome, a 32% reduction in end-stage kidney disease. Pretty remarkable. 30% reduction in composite renal outcomes and 32% reduction in end-stage kidney disease. Now, what you have to understand about these drugs is just like the ACE inhibitors and the ARBs, when you start a patient on an SGLT2 inhibitor, you're going to see an acute drop in the GFR, an acute increase in the serum creatinine. So don't be alarmed. Keep on. That is to be expected. We live in an age in which our patients see their labs on the patient portal, sometimes before the clinician does. And so you have to warn the patient, because they're going to be calling you and saying, you put me on this medication, and now my GFR has dropped. But what I always do is I explain to the patient, okay, we have patient A and patient B. Patient A has this acute drop in the GFR, but then it stabilizes. Patient B doesn't have the acute drop, but has a faster slope of progression and reaches dialysis faster. Which patient do you want to be, patient A or patient B? And then they say patient A. Okay. So warn your patients and expect that acute drop in the GFR when you start an SGLT2 inhibitor. Also be aware of the adverse effects. Genital infections, ketoacidosis. There was some signal towards more amputations in the Canvas study, but has not been confirmed in other studies. Urinary tract infections, both bacterial and fungal. So, I love this diagram now from the ADA because it now gives us some guidance on how to treat our patients who have type 2 diabetes and atherosclerotic cardiovascular disease and or chronic kidney disease. So for those who have atherosclerotic cardiovascular disease, you can look in this category, and you can see even if the patient's not on metformin, if the patient has atherosclerotic cardiovascular disease, you may want to consider GLP-1 agonists or an SGLT2 inhibitor. SGLT2 inhibitor particularly for those who have heart failure, because of all the trials that have shown this benefit of the SGLT2 inhibitors in patients with heart failure. For our patients with chronic kidney disease, add an SGLT2 inhibitor. If the patient can't tolerate an SGLT2 inhibitor or can't afford an SGLT2 inhibitor or it's not covered, then you might consider a GLP-1 agonist if that's on the patient's formulary. Okay. So the question is, how big is the drop? So like the drop that we see with the ACE inhibitors or the ARBs, it can be up to 30%. They're up to a 30% drop in the GFR acutely. Now, that requires some finesse and some thought, because now we're talking often a lot of polypharmacy. And so you have the patient on ACE inhibitor, diuretic, and SGLT2 inhibitor. And if it makes you uncomfortable, you say, okay, I'm not comfortable with that, then that's okay. Then you may say, okay, let's back off on the diuretic, because there's a diuretic effect from the SGLT2 inhibitor. Or you may say, let me lower the dose of the ACE inhibitor, because I'm just not comfortable with the amount of drop that we're seeing in the GFR. And then when things settle out, then you can up the dose of the ACE inhibitor or start it back or whatever. So sometimes it requires a little finessing, because oftentimes we're getting into a lot of polypharmacy, and that's something else we have to think about. Now, one of my big things that I talk to primary care providers about all the time is co-management. And I hope that you don't throw eggs at me. I had some verbal eggs thrown at me when I was giving a talk, and I talked about how I try to manage my patients who are on SGLT2 inhibitors, because for the longest time, I'll admit it, when I saw a patient with diabetes in my practice, I paid very little attention to the diabetes management. I would say to the patient and to the primary care doctor, your patient needs better glycemic control. But it wasn't in my bailiwick. I didn't, I said, okay, primary care provider, endocrinologist, need better control of the diabetes. And that was the extent of it. Well, then when we got all this evidence that the SGLT2 inhibitors provide benefit, then the question came, should I be prescribing it? And I will say I felt uncomfortable in prescribing these medications. Why did I feel uncomfortable prescribing them? Well, it's because of the way my practice was set up. I was in an academic practice where I had one half-day session per week. And I did not have a nurse, a nephrology nurse. I didn't even have a nurse in my practice. I had a medical assistant. And the way in which patients communicated with me was through the patient portal, and the messages could get to me a week later. And I just didn't feel comfortable that I was providing the kind of care. If the patient was having nausea, vomiting, or diarrhea, they should be able to get to me and say, I'm having nausea, vomiting, diarrhea. Do I need to stop my SGLT2 inhibitor? Or my sugar is low. Do I need to lower the dose of something else? And so for practices in which the specialist can manage all the complications, then I think that it's perfectly fine for the specialist to manage it. But if you prescribe it, then in my opinion, you need to be available to the patient to deal with the complications. And I just didn't feel it was safe in my practice to do so. So in one audience, the primary care providers got really upset, and they said, oh, you think we have all this time? I said, no. I'm not saying that at all. I'm just saying what the reality was of my practice, and I didn't feel that it was the safest thing for me to be the prescriber, because it really takes a village to manage these patients. And so what I say in my practice is I ask the endocrinologist or the primary care provider to prescribe it, and I tout all the benefits, and I say, I'm not trying to shift work onto you, but I just want there to be someone that the patient can reach out to and can get an answer to in a timely fashion when there is a complication, because I know the reality of my practice is that there's no one who can provide the answers in a quick way, and we need to be able to respond quickly. Patients should know they're having nausea, vomiting, and diarrhea to stop all of these drugs, the diuretic, the ACE inhibitor, the SGLT2 inhibitor, and someone needs to be able to get back to them quickly. So that's my spiel. Okay, let's move on to case 4. 48-year-old man with biopsy-proven IgA nephropathy returning for follow-up. He feels generally well and has had good blood pressure control on an ACE inhibitor. He's concerned, despite good blood pressure control, his creatinine is continuing to rise. His past history is notable for IgA nephropathy and hypertension. So he's on amlodipine, lisinopril, chlorthalidone, atorvastatin. His potassium is 4.1. His creatinine has gone from 1.2 to 1.67 over 6 months. His bicarb is 24. His hemoglobin is 13. And he has significant albuminuria, 1.3 grams per gram. Which of the following medications, if added to his regimen, may be of benefit in retarding progression of his kidney disease? Clopidogrel, dapagliflozin, irbesartan, or aliskiren? So any votes for clopidogrel? Any votes for dapagliflozin? Okay, I see a few hands for DAPA. Any votes for irbesartan? Any votes for aliskiren? Okay. So the best answer is B. DAPA has been shown to be effective in retarding progression of non-diabetic kidney disease. Okay, so we're getting into some new territory here. So what's the pharmacologic therapy for IgA nephropathy? Well, it's typically focused on RAS blockade, in some cases immunosuppression with glucocorticoids and other immunosuppressive agents. Statins and fish oil may be useful adjuncts. The innovation is that we now have evidence that the SGLT2 inhibitors may be beneficial in non-diabetic forms of chronic kidney disease. So what's the evidence? It comes from a trial called DAPA-CKD. This is a randomized trial of about 4,000 patients who had significant chronic kidney disease, albuminuria. Notice that the GFRs went as low as 25 in this trial. In Credence, they only went as low as 30. And all the patients were on RAS blockade at baseline. And the composites were sustained decline in eGFR of at least 50%, and end-stage kidney disease, and death from renal or cardiovascular causes. So, what were the outcomes? 39% reduction in the composite outcome, 44% reduction in the renal-specific composite outcome, 29% reduction in the composite of death from cardiovascular causes or hospitalization for heart failure, and a 31% reduction in death from any cause. Again, there was an acute drop in the GFR. So, pretty striking data for all the outcomes with DAPA in non-diabetic chronic kidney disease. What about IgA nephropathy specifically? There were about 270 patients who had IgA. So the third largest group with a specific kidney disease, the largest groups were diabetes and ischemic or hypertensive nephropathy. 254 had a kidney biopsy, and 137 were randomized to DAPA, and 133 to placebo. And you can see in this pre-specified analysis of the DAPA-CKD trial that those who were randomized to DAPA had much better outcomes compared to the placebo arm. So pretty striking data here for IgA nephropathy. So should we add an SGLT2 inhibitor to our patient? Well, the caveats are that there were still only 270 subjects. It was not clear if all subjects had received optimal supportive care. It's also not clear to what extent blood pressure reduction may have played a role from DAPA, because remember, DAPA has a blood pressure lowering effect, and there was a relatively high rate of events in the placebo group. So the skeptics of this trial would say, well, there are a few caveats here. I'm not sure we're ready to do this yet. But the data are pretty striking, and there are more and more trials that suggest that DAPA may be beneficial in non-diabetic chronic kidney disease as well. So we now, for the first time, have something that we can use as an adjunct to our patients besides ACE inhibitors and ARBs in non-specific chronic kidney disease. Any questions about the use of DAPA in non-diabetic chronic kidney disease? Okay, so we'll move on to case 5. 58-year-old man with chronic kidney disease and hypertension presents for routine follow-up. He feels well, no complaints. He's on allopurinol, chlorthalidone, aspirin, carvedilol, tamsulosin. Blood pressure is a little high, 150/90. Clear lungs, no JVD, no abdominal distension or ascites. He has 1+ pitting lower extremity edema. He's hypokalemic to 2.9. His creatinine is 2.1. He has proteinuria. His hemoglobin is 9.9. His iron saturation is 15%, and his ferritin is 30. So, simple question. Should we start this patient on an EPO for his anemia? Who votes yes? No yes votes? Who votes no? Okay. And a few abstentions. Okay. No, this patient's iron deficient. So before starting him on EPO, we want to treat his iron deficiency. So he has a hemoglobin of 9.9, T-SAT of 15%, ferritin of 30. So you all probably have seen a slide like this about the anemia of chronic kidney disease, and what you have to understand is, first, we all remember that there's decreased EPO production in chronic kidney disease. But what I want you to also know is that there's this protein called hepcidin that goes up in the setting of chronic kidney disease. And hepcidin blocks the absorption of iron. And so most of our patients who have chronic kidney disease become iron deficient. So they need iron supplementation. So our KDIGO guidelines suggest that for adult CKD patients with anemia, not on iron or ESA therapy, that we give a trial of IV or oral iron. If we desire an increase in the hemoglobin concentration without starting an ESA, and if the TSAT is less than 30 and the ferritin is less than 500. So there are a number of iron preparations on the market. Sodium ferric gluconate, iron sucrose, and ferromoxetol are the ones most commonly prescribed in the US. Now, why should we look for some alternatives to EPO? EPO is expensive. It requires intravenous or subcu administration, and there are adverse cardiovascular events. From the CHOIR study, we know that there is more congestive heart failure in those who are randomized to the high hemoglobin group. And in the TREAT study of diabetic patients, there were more strokes in the high hemoglobin group. So there's a new class of drugs that's being studied to treat the anemia of chronic kidney disease, and these are called the HIF-prolyl hydroxylase inhibitors. They stabilize the HIF complex, they stimulate endogenous EPO production, and they can be administered orally. So this is a schematic to show how these HIF drugs work. And how I'm going to summarize this is that what these drugs do is that they simulate the conditions of hypoxemia, which stimulates the production of endogenous erythropoietin at the level of the liver and other tissues. So this is a complex side, but just suffice it to say that these drugs stabilize the HIF complex, which simulates conditions of hypoxia. And that stimulates erythropoietin production. So these are some of the drugs under development. They all end in stat, and I'm not sure how to pronounce them all, so I won't do that. But there was a recent publication in the New England Journal looking at one of them specifically, the Progestat, I think I'm pronouncing it correctly, and it looked at treating anemia in both dialysis-dependent patients and non-dialysis-dependent patients. And to summarize these two trials, the Progestat was non-inferior with respect to EPO with respect to correction of anemia, and it was non-inferior with respect to cardiovascular safety. Same was true for non-dialysis dependent CKD. The Progestat was non-inferior with respect to correcting the anemia and non-inferior with respect to cardiovascular safety. So, new drugs that may be useful as an adjunct or an alternative to erythropoietin. They appear to be potentially as safe, at least the Progestat with respect to cardiovascular events, and they appear to correct anemia just as well. Okay, I'm going to try to get through case 6 and then still have time for a few questions. So this is the last case, 62-year-old woman of African descent with CKD, presenting for follow-up. Her creatinine is 2.9, and she asks about renal transplantation. So what's her GFR? Well, you can plug her GFR into some of the equations that are online. You plug in her creatinine as being 2.7 and plug her race in as being black, then you get a GFR of 21. If you change her race to other, you get a GFR of 18. So what's her true GFR? Is it 18 or 21? Any votes for 18? There are a few votes for 18. Any votes for 21? Few votes for 21. Okay. So the controversy is the use of race in calculating GFR. The estimating equations were developed from the MDRD study. Race and ethnicity were not rigorously defined in the study. So how did they define race? Well, my understanding is how they define race was that someone would look at someone and say, okay, she looks like she's of African descent, so I'm going to call her black. She looks like she's not of African descent, so I'm going to call her other. It didn't even ask the patient, how do you self-identify? So it wasn't rigorous. And over the last several years, because of that lack of rigor, many hospitals and clinics have moved away from the race adjustment factor. And there are other reasons for doing so. There's a lack of biologic plausibility that race makes such a big difference in GFR. There are many moves away from racialized medicine in general, and we may be potentiating harm to some individuals. And finally, we know that race is a social construct and not a biologic one. So is there harm in using race, specifically for GFR? So let's look at some of the data. There was a recent analysis from a large chronic kidney disease cohort called the CRIC cohort. And what they did was that they looked at the time to achieve a GFR less than 20. And you can see that without using the race coefficient, one reaches a GFR less than 20 sooner than if you use the race modifiers. So here, without the race coefficient, and here with the race coefficient. Why does this matter? The reason this matters is that that's the cutoff for getting listed for kidney transplantation. So that arbitrary definition of 20 above, not eligible for kidney transplantation, 20 or less being eligible for kidney transplantation, can matter. Now, there are some downsides to removing race from the estimating equation for people of color. So you're going to increase the number of people defined as having chronic kidney disease who are of African descent. So in the VA cohort, there was a doubling of the prevalence of CKD among black adults without using the race modifier. And it's going to have effects on medications that can be prescribed. So without the race modifier, fewer patients of African descent are going to be eligible for metformin. And we know that metformin is one of the medications that we use a lot in our patients of African descent who have diabetes. So there's some trade-offs here. We're removing the race modifier, and maybe we're removing a potential barrier to transplantation, but it also means that we have to think about medications and that we're going to reduce the number of medications and clinical trials. We also want to increase the prevalence of patients of color in clinical trials, and since we're going to have more patients now defined as having CKD, it means that we're going to have to work harder to get our patients who have normal GFRs and are of African descent into clinical trials. Now, fortunately, there are some new equations, new GFR equations that incorporate creatinine and cystatin C but omit race, or more accurate, and they lead to smaller differences between black participants and non-black participants than new equations that only use creatinine. So how many of you have the availability of ordering cystatin C in your practice? Okay, so something worthwhile to take back to your practices. Can they make cystatin C available? Because cystatin C is going to be an important way of reducing some of the disparities in estimating GFR in our black versus our non-black patients. Kidney disease, as you know, disproportionately affects people of color. Compared to Caucasians, the end-stage renal disease prevalence is about 3.7 times greater in African Americans, 1.4 times greater in Native Americans, and 1.5 times greater in Asian Americans. This graphic illustrates it nicely here, where you can see the adjusted end-stage renal disease rate for people of African descent compared to other races. Now, we've had some improvement, but there still is a lot of difference between those who are defined as black versus those from other races. Now, one of the things that we've learned over the last few years is that there are some genetic reasons for this disparity in kidney disease, and that is what's called the APOL1 risk alleles. And if you have two copies, 2 copies of this risk allele, you're at higher risk of kidney disease than if you have 0 copies of this risk allele, ApoL1. And the interesting story about this is that in evolution, these ApoL1 alleles evolved to protect against the trypanosome that causes sleeping sickness. But the trypanosome can invade the lysosome, can invade the cell, and then the lysosome will swell and kill the parasite. The parasite then evolved to develop this resistance to that lysosomal killing mechanism. And so in evolution, we developed these alleles here that protect and again allow this trypanosome to be killed within the lysosome. But we now know that this evolutionary change modified the risk of kidney disease. Now, it takes something else in addition to having these ApoL1 risk alleles generally to bring out the kidney disease. And interestingly, what is it? What's the other thing? It's often a virus. So that's why HIV nephropathy is so much more common in people of African descent than it is of people of Caucasian descent. And guess what we learned during the COVID crisis? Patients who have 2 ApoL1 risk alleles were also more likely to develop kidney disease in the setting of a COVID infection. All right. But genetics only accounts for a very small portion of the disparities in chronic kidney disease. So in your practices, you have to be thinking about everything else that's causing our patients of color to have more kidney disease. That's really taking a holistic assessment. It's poverty, it's poor education, it's lack of appropriate housing, it's food insecurity, it's race and racism that lead to stressors that are exacerbating the underlying disparities in chronic kidney disease. So we have a lot of work to do. I have 8 minutes left, so I can take some questions. Thank you. Yes, ma'am. Corindia. Corindia. Give me the generic name. I'm sorry, I don't know that. I think Corindia is one of the new mineralocorticoid blockers, but I want to make sure I'm giving you the Finerenone. Very good. So thank you. So finerenone is again something new. I didn't cover it today, but it's again a new mineralocorticoid blocker. And it also, unlike spironolactone, it has a more beneficial profile with respect to potassium. So it doesn't raise the serum potassium as much. And we have new evidence from the Figaro trial and Fidelio trials that they also can retard progression of chronic kidney disease. So it's something else that we have in our armamentarium in addition to SGLT2 inhibitors and GLP-1 agonists, that finerenone may be an additional adjunctive therapy for blocking the progression of chronic kidney disease. So yes, more and more evidence that suggests that finerenone from the Fidelio study and the Figaro study is helpful in retarding progression not only of kidney disease but also cardiovascular disease. Yes, ma'am. Yeah. So that's a good question. Should we avoid those drugs in people who have COPD? I don't think that there's any contraindication to using those drugs in patients who have COPD because their HIF mechanisms are probably already ramped up. Yeah. I don't know. I don't know the answer to that question because I don't know specifically. I'd have to look back at the trial to see if they excluded patients with COPD from the trial. But that's a good question, to which I don't know the answer. Yes, sir. So the question is, is DAPA the only one that is indicated for chronic kidney disease? So DAPA is the one that we have the most evidence for because of the DAPA-CKD trial. Now, I think most nephrologists think that there is a class effect, that the drugs, irrespective of the individual drug, if they belong to that class, they will provide that benefit. And so I think we are using them broadly, so whether it's empagliflozin or canagliflozin. And the reality is that in the limited number of patients that I personally prescribed them, that their formulary is quite limited. And so if someone has canagliflozin on his or her formulary but not dapagliflozin, but the patient has IgA nephropathy, and I think that an SGLT2 inhibitor would be beneficial, absolutely, I would go for the canagliflozin if DAPA is not available. But I think your point is well taken that we have the most evidence. Just as for diabetes, we have the most evidence for canagliflozin because it was the first trial that really looked specifically at diabetes and chronic kidney disease. But I think most nephrologists think that there's a class effect and will go for, especially since formularies are so limited.
We have a few questions that came in. So one is about genital mycotic infections / urinary tract infections and SGLT inhibitors. They want to know at what point do you discontinue? There's some verbiage about 1 to 2 years.
You mean after a genital or mycotic infection?
I think they're saying they say the rule of thumb is 1 to 2 years due to chance versus medication-related infections. So I think they're saying preventatively to make sure
in
that
someone who's had a mycotic infection to wait 1 to 2.
They didn't really specify.
So let me try to answer the question kind of broadly. Yes, genital and mycotic infections are a problem in patients who are given SGLT2 inhibitors. And if you think about it, you're putting sugar into the urine, and so you're making the patients at greater risk, not just for genital and mycotic infections, but also we know that particularly in obese men, there's a higher risk of Fournier's gangrene, which can be a huge, huge mess. So my rule of thumb would be if someone has a genital or mycotic infection, I would probably stop the SGLT2 inhibitor for a period of time until I know that the infection has cleared. Now, I don't know if there's good guidance as to what that period of time is. I would probably, for my own comfort, wait at least 6 months before attempting a restart, but that's just from my own comfort level. But I think, yes, be vigilant for genital and mycotic infections because I think they can be probably one of the more serious adverse consequences of these new medications.
Thank you. And our last question is, when should you refer to the PCP, the initial workup for CKD, or at what stage in chronic kidney disease?
So I generally think that any patient with stage 3 chronic kidney disease should be referred to a nephrologist. It may be that everything appropriate has been done, but I think at least the patient has then established a relationship with a nephrologist, so if the patient advances, then those conversations regarding advanced therapies, dialysis, transplantation can be had. Or patients with less advanced chronic kidney disease that you are uncomfortable there's something else that is going on. Your spidey senses tell you that there's something else that you can't quite figure out. Send the patient on because I've had many patients who I found out had something else. They might have diabetes, but it wasn't the diabetes that was causing the kidney disease. It was something else, and we found it out only by a kidney biopsy. So when somebody doesn't feel quite right, send the patient on because you may be absolutely correct that there is something else going on and may require kidney biopsy sometimes to figure it out.
Thank you so much for your wonderful presentation.
Thank you for your attention.